Hello everyone. I'm trying to explain the various problems, investigations, diseases and management related to the gland called thyroid gland. It may not be possible for me to cover the entire aspect in one single go, and hence I thought it is good to have in different episodes. To begin with, thyroid is a gland in the human body, and the human body has got many glands situated at different parts in the human body. Most of them do have their secretions which are brought out through ducts, but a smaller number of these glands do not have any ducts to bring its secretion into the human body. Such glands whose secretions directly go to the blood are called the endocrine glands, otherwise called the ductless glands. There are a few endocrine glands distributed all throughout the human body, what we call as the orchestra of endocrines, or the endocrine orchestra more precisely, which is controlled by an endocrine gland called pituitary, which is situated inside the human brain. It controls the rest of the endocrine glands in the human body. Thyroid is a very common problem which patients comes and describes to the clinician. The problems in the thyroid gland are variable, highly varied, and hence it can reach different specialists depending on the type of presentation it makes. Basically, it can be divided into local symptomatology pertaining to the neck area, or symptoms which are pertainable to the secretions which it gets into the human body. So it can have effects on the cardiovascular system, it can have its effect on the gastrointestinal tree, it can have its effect on the sexual functions, it can have its effect on the brain. So the ways by which a thyroid disorder will present to the clinician can be in different ways. Let's try to understand the origin and the development of thyroid gland. It starts in the fetus inside the mother's womb as an outgrowth from the junction of the anterior or the front 2/3 of the tongue and the posterior 1/3 or the back 1/3 of the tongue, what we call in science as a foramen cecum. This descends from the base of the tongue to the neck during the development of the fetus and settles down in front of the neck, in front of the trachea by adulthood. During the passage of descent or the pathway of descent, the thyroid is capable of halting at different levels, and these are responsible for the various congenital anomalies of the thyroid, which I'll take up at a later time. Now let's first understand when a patient comes to you with a thyroid problem, how a clinician is going to look at it. There are basically two types of thyroid problems. Number one, things which are pertaining to the secretory part of the thyroid gland, and the second part is that pertains to the anatomical configuration of the thyroid gland. The diseases which pertains to the secretory part are generally medical in nature, whereas the anatomical variation, including the developmental problems, are mostly surgical in its nature. Thyroid, as I told you, is capable of secreting a hormone, the thyroxine, which is secreted entirely by the thyroid gland, occasionally by thyroid-like tissue elsewhere in the human body. But the substrate from which it gets its thyroxine is iodine. Iodine is available in the food material. It is also available plenty in the water. It is also being supplemented across the country by iodized salt. This is basically from the finding that Himalayan foothills showed enlargement of thyroid earlier on, and the entire region were having people living with large thyroids. So studies have been conducted and they found that the dietary intake of iodine is less in these areas, and hence dietary supplementation could actually alleviate this problem. The substrate being iodine, it is absorbed into the thyroid gland, goes through different chemical processes and gets secreted into the bloodstream as different combinations of iodine-based thyroxine. We call it as T3 and T4. One is a metabolically inert form, the other one is a metabolically active form. There is a constant negative feedback mechanism which operates between thyroid gland and the pituitary gland. The more the thyroxine comes out, the pituitary gets suppressed and the pituitary produces less and less of a stimulant hormone to the thyroid, what we call as the TSH, thyroid stimulating hormone. So when the T3 and T4 level goes high, there is a negative feedback mechanism operating at pituitary gland, reducing the secretion of TSH, and hence the stimulation to thyroid goes down. It produces less and less of T3 and T4. So it just balances. The functional abnormalities of the thyroid can either be more production of thyroxine or less production of thyroxine. The less production of thyroxine is called a hypothyroid state, whereas the more production of thyroxine is called hypersecretory stage, is otherwise called hyperthyroidism. Hypothyroidism occurring in children before the growth gets completed, if it is not identified and corrected, will result in what in medical science we call as cretinism, which is short-statured, dwarfy human beings, which is currently getting out of our clinical scene because this condition, rather the hypothyroidism, is detected efficiently by the pediatricians, by the neonatologists, by the pediatrician, well in advance, and supplemented with enough of thyroxine, so we don't get generally into a state of cretinism, but still it is possible. When the thyroid secretions are low in an adult, it can give rise to many features of hypothyroidism. Its effect on the central nervous system is a reduced alertness, feeling of being lethargic, listlessness, don't get the energy to work, so the people would prefer to be sedentary, less interested in their work. They are more sleepy, they sleep early, their sleep is prolonged. So these are some of the effects of hypothyroidism in the central nervous system. In the cardiovascular system, the heart rate goes down, the pulse rate goes down, and this has got its clinical presentation of its own nature. It also affects the gastrointestinal tract by way of producing constipation. On a menstruating female, on a lady, this can give rise to menstrual irregularities in the form of more frequent periods and high flow during the time of periods with many times pain. The other effects can be on skin. The skin can become thicker. The tibial area can become more thicker. There is a facial edema. So these patients can also get presented with the general physician by these complaints. Skin manifestations are also well known in hypothyroidism, particularly when it is associated with some autoimmune background. On the contrary, the hypersecretion of thyroid hormones can have effects which are just opposite to what I have described. In the central nervous system, the patient can become irritable, patient can start fighting with others, they are not able to concentrate on one particular field, their concentration capacity loses. So these are the central nervous side effects. On the cardiovascular system, the patient can have tachycardia, that is the heart rate going high. The patient feels palpitation. The patient sweats in excess of normal. The skin, is wet, moist. The tachycardia does not stop there if it is untreated. You start getting extra beats. In clinical terms, we go to sometimes diagnose atrial fibrillation, which means that the heart is pumping, heart is having a big heart rate but ineffective pumping. So there is a disparity between heart rate and the pulse rate. This can precipitate cardiac failure too. On the gastrointestinal system, just contrary to constipation, we can have diarrhea, malabsorption states, and the net result of all these things put together, we call it a hypermetabolic state, and the patient would start losing the weight. On the reproductive system, the patient can have less of periods, frequency of periods can come down. So all these things can happen in a hyperthyroid state. Both hypo and hyperthyroidism are essentially medically treatable disease.